Cartwright.
Good morning, my lady. The gentleman by the witness box is Sir Paul Nurse. Could I ask, please, for him to be sworn?
If you'd like to repeat after me, I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
that
the evidence I shall give
the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you very much.
Could I ask you, please, to provide your full name to the inquiry?
Of course, Paul Maxime Nurse.
Thank you. With your permission, I'd like to refer to you throughout your evidence as Sir Paul. Could we first of all identify the witness statement you've provided? There should be a copy brought up on the screen in front of you. It's INQ 587302. Could we turn to page 44, please, of that statement, which is dated the 9th of April 2025. I can ask you first of all to confirm, are the contents of that statement true to the best of your knowledge and belief?
Yes, it's true to the best of my knowledge and belief.
Thank you. Now, it's correct, isn't it, Sir Paul, that the statement has been provided to effectively represent the corporate position of the Crick Institute?
That is correct, yes.
And perhaps for completeness, it's also right to identify, and we don't need to go to it, that you also had contributed to a statement that Module 7 has received from the Microbiology Society.
Absolutely correct too.
Thank you. So, Paul, before we deal with the Crick and what the Crick is and the importance of what the Crick did in the pandemic, could we first of all identify yourself and your professional background and qualifications, and then we'll move to the detail, please, of the Crick. It's right, isn't it, that you have a degree in biology from the University of Birmingham?
I do.
That in 1979 you set up your own laboratory at the University of Sussex.
I did.
In 1984 you joined the Imperial Cancer Research Fund.
I did.
Which became Cancer Research United Kingdom in 2002.
I did.
And you have done an awful lot of work in respect of genes. And it's right, isn't it, that for your work generally, you were awarded in 2001 the Nobel Prize in Physiology.
I was, physiology or medicine.
Thank you. So moving on from your time at the Imperial Cancer Research Fund, it's right, isn't it, you left in 1988 to chair the Department of Microbiology at the University of Oxford.
I did.
You continued your work on cell cycles there and also new research areas in genomics.
I did.
In 2003, you were president of the Rockefeller University at New York City.
Yes, I was.
In 2010, and this brings us, I think, to what you're going to speak about today, you became the first director and chief executive of the Francis Crick Institute in London.
I did, and I still am.
Thank you. And it's right, isn't it, that for 5 of those years you've been president of the Royal Society?
I was.
And in fact, you will be returning to the role, I think, in December of this year to be president of the Royal Society.
I will be doing so.
That's only a snapshot of your knowledge and experience. Is there anything else about you, Sir Paul, that you'd like to identify that's going to be relevant to anything we talk about in respect to test and trace?
No, except I'm not a clinically trained researcher. I'm a biological researcher.
Thank you. Can I then turn to you to tell us what the Crick Institute is, but also the significance of the skills and expertise and equipment that is held at the Crick Institute that is relevant to test, trace and isolate, please?
Yes, I'm delighted to do so. The Francis Crick Institute was founded just 10 years ago, moved into its new buildings next to St Pancras. It is funded by 3 biomedical funders, Cancer Research UK, Medical Research Council, government one step removed, and the Wellcome Trust. It is a large institute, around 1,300 permanent scientists, 200 or 300 visitors, so it's the biggest biomedical research institute under a single roof that I'm aware of. And it covers a whole wide range of fundamental science into biology and biomedicine, a total of 120 research groups. It has rapidly established its reputation. Of those 120, a good reputation. Of those 120 research group leaders, 4 are Nobel laureates, 2 emeriti and 2 who are still active, and I believe about 27, 28 Fellows of the Royal Society, so a very high concentration of talent. It is also a very well-equipped institute, reasonably well funded, and covers a wide range of research activities with a wide range of different technologies.
Thank you. You've identified the Nobel laureates, and I just want to identify another one of them by name because it will become relevant to some of the correspondence we look at together. Is it right that one of the 4 that you'd identified is Sir Peter Ratcliffe, who is the Director of Clinical Research, but he is also a Nobel laureate?
He is, and I should say he's probably the most distinguished clinical researcher in the UK today.
Thank you. Now, you've given an overview about the skills and expertise, but when we look at the statement, and the statement will be published, it's clear that in terms of the expertise that exists, it's expertise from an international perspective. I think you tell us that there's individual experts from over 80 countries that work within the CRIC.
Yes, we are very international. We have approaching 80 different nationalities working there. We are able to recruit the best from the world. When we actually search for a new group leader, we get nearly 500 applicants from around the world.
Thank you. Now, unless there's anything else you want to say about the CRIC, the full details are in the statement, but I'd like you to assist Her Ladyship with when the pandemic happened, and certainly around January time, the relevant steps that the CRIC were taking when they identified that something significant had to be done in respect of testing, please.
Yes, when we saw the pandemic coming, we had about 20 clinically trained group leaders who came to see me, or a subset of them, to say that this was likely to be a very significant pandemic. And we looked very quickly at whether the Crick Institute could assist the country in dealing with that. We rapidly realized that we would be able to assist with testing because the equipment and skill sets were very well represented at the Francis Crick Institute. We'd never done routine testing before, so it was something completely different from what we would normally do. We're a research activity, we're not an NHS support facility. But we realized we had the skill set and the people, and of course very rapidly they were sent home or on furlough, or would have been sent home on furlough, and we realized that we would be able to contribute to the testing facility in a limited way, locally, but very rapidly. And we perhaps realized rather quickly that the plans to establish very large testing facilities, the Lighthouse laboratories, would take many months to get properly functioning for both scientific and logistic reasons. Yet we would be able to get something in place to deal with the more vulnerable individuals in society and healthcare situations much more rapidly in a matter of weeks. So we started planning to do that from early February onwards.
Thank you. And can I ask you then to provide the details of the CRIC consortium, because it's right, isn't it, that partnerships were entered into, including with local NHS trusts, as part of the thought process around what you've just described for getting some testing up and running?
Yes, we set up a CRIC COVID consortium, we call it CCC for short. And just to summarise it logistically, really, what we did is we plugged our testing facilities into pre-existing pipelines into hospitals and eventually into care homes, so that they were already in place, if you like, embryonic logistics that could be put rapidly into a more rapid and larger testing facility if they had at the front end the ability to test. So we provided the ability to test and connected it to local hospitals and care homes.
Thank you. And can we just ensure we've identified those in the partnership? It's right, it was University College London Hospitals, NHS Foundation Trust, care homes, but also you had the input from the health services laboratories. and a UK accreditation service recognised clinical diagnostic laboratory. Can you just provide the details as to why they were important to be in the partnership, please?
They were really critical because, if you like, they gave the sort of legal cover and the accreditation that we as a research laboratory wouldn't have. And that's really what I was trying to emphasise, is that we stepped up the ability to do the lab work, connecting with pre-existing legal support and facilities that then would connect into the hospitals. That was what was special about this.
Thank you. I'm going to briefly display a document that just helps identify the hospitals and community hospitals that the pipeline then provided with testing. It's please 587047. That's INQ 587047.
Yes, I think that I haven't that in front of me, but
It's okay.
yeah.
Whilst it's being displayed, and if it can't be displayed, there's no issue. But it's right, is it? Thank you. Could the bottom
Yes, I have it now.
expanded? Thank you. That essentially the pipeline provided testing to the 13 acute hospitals listed there and 5 community hospitals.
Absolutely correct. All in, essentially, mostly in North London. Yes.
Thank you. And I don't think that's a complete picture of what was supported, because if we look over the page, although they're not listed, we know that it went to 200. You can see at the top of the page, additional locations included care homes, mental health facilities, crisis centres, GPs and medical centres.
Absolutely correct.
Thank you. That can be removed, please. And you've already mentioned what could be achieved because of the local connections. Can you perhaps expand upon the benefit of how the creek was able to operate because of it being part of a local infrastructure?
Yes, I can. It's really a sort of sticking plaster approach, if I may use that metaphor, because it was local and because we knew many of the people involved, or rapidly got to know them. When there were difficulties, when there were issues, when we lost samples, when the IT didn't quite work, we could literally get on a bicycle and sort it out. I remember one case that a GP needed a test within hours. We managed to get them to them in hours. That happened frequently. That's really difficult in the big lighthouse labs, because it has to be like that. If you're in Milton Keynes and doing testing for Staffordshire a couple of 100 miles away, you cannot solve problems with sticking plasters. But we could, and it's one reason we were so effective. We never could work at the same scale, but we could provide a service that gave, and we did, a 24-hour turnaround from the very beginning. And if you are dealing with a pandemic, that sort of speed is absolutely critical to protect vulnerable people. Absolutely critical.
And is that when you say the 24-hour turnaround, that's from being tested and having the results available?
Absolutely. So you give your sample, you would know the answer within 24 hours. And nearly everything we did was in that timescale.
Thank you. Now, it seems an important observation and point that you wish to make around the speed of turnaround and the importance.
Yes.
The obvious reason you've given. Why are you wanting to particularly draw that?
I want to bring that attention because even when the Lighthouse labs, which had to be put in place, I mean, we needed mass facilities, they would count it as working well if they had a 7-day turnaround. And 7 days is a very long time when you're dealing with vulnerable people in vulnerable healthcare situations for all sorts of reasons, which I think will be obvious. 24-hour turnaround is really important in this situation if you are to provide the appropriate protection of patients and other vulnerable individuals.
Thank you. Perhaps if I identify this as a theme, we'll perhaps come back to on the chronology when we look at the Lighthouse Laboratories. I think you have been referenced by myself in opening, but also in press at the time, where you describe essentially that there's the need for the small boats of organisations like the Crick to operate.
Yes, I stole a metaphor from Dunkirk, of course, with the big ships and the small boats. I stole it from my wife, actually, who suggested it when I was going on the Today programme the night before. But I think it is a good metaphor, it is a good analogy. We needed the big ships, but we had to appreciate that they would take time to be put in place and that we had to do something before they could get in place, and they would probably always be a bit slower. The little boats, on the other hand, such as the Crick, could produce, as I've explained, much more rapid turnover and getting the data back, and would be very essential at the beginning of a pandemic, because if you don't know where the infection is, you can't actually take any ways of preventing it. So it's absolutely critical.
Thank you. And we'll look together in a little time at an article that one of the members of the Critical Consortium wrote, where I think if we have the lighthouses, they described what laboratories like you and others were doing as the lifeboats.
Yes, that's another good metaphor. Yeah.
Now, at a very high level, can we just deal with the logistics and the infrastructure that you had at the CRIC? And particularly, we know that the gold standard test at that time, early in the pandemic, was PCR machines. And just from a logistical point of view, can you give Her Ladyship, please, some idea about how many of the PCR machines the CRIC held?
Yes, so we had the machines and we had the expertise, just to make that critical. We had about 50 PCR machines operating in the building. We also needed containment facilities, and we had good containment facilities, I mean, of the sort you would find in a local hospital, but we had about 20 of them, and those were critical. Both of those items were critical.
Thank you. And just pausing there, because I've introduced the containment levels and how initially the pathogen of the coronavirus was being treated as a containment level 3 virus before then the HSC and the ADCP downgraded it to a containment level 2. So just to be clear, is it correct that when you gave those figures that there were, certainly you had 20 PCR machines and facilities that could operate at containment level 3?
Not PCR machines.
Sorry,
we had the containment facilities that could operate at containment level 3 very effectively, yes. And the 50 PCR machines that could service them, yes.
Thank you. So can I just understand, because the distinction you were making about the different PCRs, is that dependent on where they were being used in the containment levels?
No, the PCR machines are a machine that allows you to detect the presence, in this case, of the virus. So that is a piece of kit that, with the right people running it, could tell you whether the virus was present in a sample. The containment facilities were important for safety purposes, essentially to kill the virus before you actually did the analysis.
Well, I think perhaps to best show this, can we use your witness statement, please, where we've got the description of that, and it's your statement, please, 587302 at page 13. You've helpfully extracted from the article I referenced a moment ago the process, so we could expand the image at the top.
Yes, this is very useful. What you can see here, we have to take a sample, and that has to be barcoded scanned so it can enter into the IT system. I mean, that's the starting point. This means, of course, you have to have IT that can deal with this.
And just pausing there, we'll look at the article, but you did have the IT
We did. We had to modify it, of course, but we had the skill set to be able to do that rapidly. I want to emphasize, we don't normally do this sort of thing at all. So we had to do it from scratch. And so we had to modify what we had, the IT facilities, to be able to deal with that. That means we had a sample and we could know where the patient or the person producing it, who it was, and it was anonymized, of course, and who it had to go back to. It was then opened in a safety cabinet, which
is the next part.
Which is the next one.
And I think this is where, with the containment levels, because it's essentially a hood, isn't it? And is it the circles that we see, essentially, that's where your hands would go in as you're handling the virus? Yes,
exactly. It's a containment facilities. You put your hand through those two holes there into gloves, and that means you can manipulate the sample safely. And as you rightly said, initially at containment level 3, and then subsequently at containment level 2. That would allow inactivation of the virus, so it then became safe. It then had to be plated out, you see a 96-well plate, so that this allows us to analyze samples at scale. So we could do 96 individual tests simultaneously in that particular plate. We had to extract the RNA.
I'm just pausing there. I think a little bit of help about RNA and what that is in the virus and how that's important for identifying whether someone's got positive for COVID, please?
Indeed, I will happy to explain that now. Every virus has a genome. We have genomes too. Our genome is made of DNA, that is deoxyribonucleic acid. Viruses can be DNA or RNA, which is just ribonucleic acid. In the case of coronavirus, it was an RNA virus. So if you like, encodes the genes that make the virus work. If you can extract the RNA out of the virus, which is what we did next, then you can use the PCR machine, I'll come to that in a moment, to determine whether that RNA comes from the COVID virus. And so then after RNA extraction, you go to the PCR machine. PCR means polymerase chain reaction. It's just a technique which allows us to detect what sequences are present, and we know the signature sequences of the COVID virus. So that allows it to be tested to see if it is positive or negative. Then, of course, you have to go back through the logistics right to the beginning again to actually get that information back to the patient or the person giving the sample. And we aimed at doing all of this process and getting back to the patient, the logistical issue, which can be slow, in less than 24 hours. When necessary, we could do it in 8 hours.
Thank you. Just dealing with, we've dealt with PCR, but can you just explain again at a high level what the RT, the reverse transcription, means, please?
Oh, I can. It gets a bit more technical, of course.
Well, perhaps at a very high
Slowly
level.
then, please.
At very high level. We have RNA, which is essentially a molecule made up of different letters, chemical letters. And these chemical letters can connect to other chemical letters that we can construct, so that it allows us to detect, if you like, the presence of a particular sequence of letters. And that's what this process is going. And essentially what happens is that we copy the molecule, and then we copy it again and again and again, maybe 20 times. So it turns from being one molecule, which is infinitesimally small, into many millions, and then we can detect that in the assay that we do.
Thank you. Now, I think just with looking at an example of a PCR machine, which is the machine at the end that identifies whether someone's positive for the COVID virus or negative, I think there are a number of manufacturers of PCR machines. And are you able to give us any idea as to the PCR machines that the Crick had, or was it a mix of manufacturers of the machines?
It was a mix of different manufacturers. We'd actually inherited them from we merged 3 institutes to make this one. The equipment was actually quite old. It worked quite well. We had some new equipment, some old equipment, some large, some small, all of which could be used in this particular process. Of course, if you were doing a tiny testing lab, you'd have all the same machine and it would be more standardized. But we could put into the testing regime all the machines that we had.
Thank you. And can I ask you, just because it may be relevant also, how are the Crick, to do this process, you also need reagents, is that correct?
Yes.
And how are the Crick making or getting their reagents to be able to do the PCR testing?
Well, this is interesting you should bring it up, because in fact, as you could well imagine at this time, sourcing these reagents became quite difficult because they were in demand across the world. But being a research institute, it was rather trivial for us to set up a line that could make the reagents that we needed. That would be more difficult in a conventional testing lab, but we were able to do that. So that when we were lacking a particular reagent, we just made it ourselves.
Yeah, and so that was possible at the Crick, also you could make the reagent to do the testing?
We could make it at the Crick, but also there would be many other academic-type research institutions and universities which would be able to do it. It's relatively trivial, but it wouldn't be, if you like, the sort of thing that a company would normally do in a normal testing laboratory.
Thank you. Now, the way you repurposed the Crick, it's right to say that you weren't being paternalistic or protective of it. You shared your standard operating procedures that were accessible on your website, that essentially what you'd achieved could be copied or mirrored at places that had the equipment and the facilities?
Absolutely. We made that a priority. Once we'd sorted out how to do it, we also worked out how a conventional research laboratory like the Crick could be rapidly repurposed in a couple of weeks into quite an effective small testing facility. I say small, I mean, we were doing, in the end, 3,000 to 4,000 tests a day. We started off around 1,000, but there would be many places in the UK, academic institutions, maybe some other small companies that could be rapidly repurposed to produce that sort of output.
Now, we'll look at the correspondence. You do identify a figure that you could get to, I think, the 3,000 to 4,000. But I think there's also an indication that had there been more money and more facilities, that the Crick could have increased that figure again to what would have been possible at the Crick by way of daily turnaround of testing. Are you able to, and if you're not, please don't speculate, but are you able to give some idea of what could have been possible for volume testing at the Crick with more investment or money?
Yes, because we were using our research money, of course, for this purpose. So, I mean, we were somewhat restrained by money. We weren't restrained by numbers of workers because we had many who were skilled. I think we could have scaled up to around 10,000 in a month if we'd had the money. And given what I've already said, that there's nothing that special about the Crick except we were prepared to do it and to do it very quickly, that could have been rolled out using our protocols to 30, 40, 50, maybe more places in the rest of the UK. I'm guesstimating there. I haven't actually counted them, but I'm thinking of research universities and other research institutions. So if you just do the simple maths there, you can see that within a month or two, we could have had 100 to 200,000 tests, which would be turned around every 24 hours, locally set up. And that, I think, would have been a very effective way of dealing with the early days of the pandemic.
Thank you. And so I just want to be sure that we're clear about the timeline and the volume. I think you'd indicated you think it would have taken the Crick a month to get to a potential ability to have then 10,000 tests a day. I'm
estimating we'd need to do a proper study of that, but yes, I think that would be reasonable.
Thank you. And you,
did you just sorry to interrupt?
Sorry, no,
did you discuss with your colleagues these? You obviously all discuss things at different times. Did you discuss with your colleagues who headed these other institutes as to what their plans were and what they could do or couldn't do?
We didn't discuss. We sent it all out, and there were informal discussions. There was a great deal of interest in doing it, I have to say, but there seemed to be many obstacles. Some of the obstacles were a lack of interest from, if you like, the central, both government and maybe the testing services, who were totally focused on Big Lighthouse. So there was a real lack of interest. I think that was one problem. I suspect also, but this is hearsay, so I'm afraid I'm not sure about this, there might have been a certain reticence or reluctance in some institutions. You know, did we have the right insurance? Were we legally in the right position? All the usual sorts of things that maybe in peacetime you would really have to take seriously, but in wartime, perhaps you could be a little bit more bold about. I think the Crick was in a special situation that we controlled our own finances, we were bold, we got things working. What surprised me was that wasn't taken up centrally. With that support centrally, then I think we'd have given confidence to the universities who might have been perhaps a little more timid than we were to actually roll this out. So I think it needed boldness in the political leadership centrally would have made a very significant difference. It's my opinion, of course, because we did not do that.
Thank you. Can we then look to the correspondence that you and others at the Crick entered into?
Yeah.
And can we start, please, first of all, with its INQ, please, 587053. Thank you. So here we have 10th of March, your email to Patrick Vallance with Chris Whitty on copy.
Yes.
And perhaps if I read it, just to contextualise, we've got attached to it was the CRIC work to support COVID-19 research, which we'll look at in a minute briefly. But you say as follows: Dear Patrick, in view of the current situation with COVID-19, I thought you might like to be aware of what work the CRIC is currently undertaking to support the research endeavour. I've attached a short summary. If there's anything in this summary you would like us to prioritise, please let me know. The CRIC obviously only has certain expertise, but I'd like to offer any support we have that might be useful to you. For example, we could use volunteer laboratory staff if needed for diagnostics, or offer use of our high-quality containment or our general lab facilities. Please do let me know if there's anything else you feel the CRIC can do to support the overall effort against COVID. And then over the page, please, to page 2. This is the attachment to the email. Thank you. Thank you.
Hiya.
We can see, I'm not going to read it, but it will be published. It essentially summarises. And go to the next page, please.
Yes, this is. Sorry. Yes.
Sorry, thank
Keep
you.
going.
And over again, essentially it was giving the detail of what could be achieved and what was being offered. And then I'm going to take us on to the next page, please, page 8. Sorry, over again, because, sorry, it's page 7. I do apologise, because then we'll pick up the correspondence from that point. So when that was sent, can you assist about the response you had back to that offer of what could be achieved at the CRIC?
Well, I'm trying to recall. I think Chris Whitty responded positively. And what we were offering there, just to be clear, was everything we could do, which was testing, which we've spoken mostly about, and which, of course, is what you're looking at here today, but also research activity, which we could repurpose from what we normally do to a focus on the coronavirus. So we did have a response. You see there from Chris, who I'm sure was extremely busy at this time, but I don't think this was picked up centrally to be able to turn these offers, and at this moment they were perhaps a little vague, into a more comprehensive local testing. I mean, that was where we eventually ended up, in fact, in only a few weeks, but we weren't so specific at this stage, I would say.
Thank you. So I'm going to start at the bottom of this page then as to the next piece of correspondence, please. The 17th of March, Peter Ratcliffe, who we've already identified from the CRIC, one of the Nobel laureates. Thank you. If we can go over the page. Essentially, you're saying, as you know, I'm the Clinical Research Director at the Francis Crick Institute. Again, a follow-up saying that we're here to help effectively. At present, I'm contacting heads of NHS labs in London and Oxford to determine if they can deploy extra personnel as the easiest first step. And also then say we'd also scope out methods, reagents, equipment. And if we can then go back a page to, please, page 6. Sorry, page 7, I do apologise. We can see that Mr. Whitty responded on the 18th of March to thank Peter and say that I'm ceasing my government address and I'll discuss with the team there. So an acknowledgement and the fact that it was to be discussed. But I then want to take you, please, if we follow the chronology, to you taking up the mantle again on the 19th of March, which is our internal page 6. And can you give a sense now, the initial contact was the 10th, we're now at the 19th of March, where you are now emailing Mr. War, who was at that time Special Advisor to the Prime Minister for Health, Social Care, Life Sciences and Technology, and Minister Nadhim Zahawi and Greg Clark. Can you help us to why you were sending this email and why you were going to those individuals in particular, please?
Yes, I think what we decided at this point is that we told the science and medical advisors, Patrick and Chris, but we thought that we needed to try and persuade government to take this seriously, and this was our first attempt to do so, and we sent it to Mr. Waugh, who was, I believe, an advisor to the Prime Minister, again briefly summarising what we could do and indicating, as you see there, that when we, within 24 hours of asking our staff, we had 300 who volunteered they would come in, and remember, not being paid, because they were already furloughed, and so no cost, in fact, extra cost. We only needed money for the for reagents and maybe for new equipment, just to indicate at the highest level, at the level of the Prime Minister, what was possible at the Crick, and then, of course, subsequently, what would have been possible had it been rolled out across the country.
Thank you. So, as you've already indicated, this is you indicating that the support to scale up diagnostic testing was being offered, that you were aware of a significant diagnostic bottleneck with PCRs, that you had that large number of qualified volunteers ready to help, nearly 300. And as we can see on the next paragraph, that the Crick also has significant capacity that could be turned over to testing, including 20 Class B fume hoods in containment level 3, and a very large number of lab spaces that are ready to be turned into a containment level 2 space. And we can see the offer that you were prepared to quickly turn significant resources over to that work.
And of course, we did turn most of it over. I mean, not quite at the scale, as I've already indicated, that perhaps we could have done, but we did turn it over quite quickly.
And we will see that then in the next piece of correspondence, please. Moving along in the same document, please, to page 9. And we're now at the 1st of April of 2020. And can I ask you, in response to the email that you sent of the 19th March, did you have any response?
We didn't get any response from William Waugh or the Prime Minister to that letter, no. We did not.
Now, we next see your letter of the 1st of April, now on Crick-headed paper from the 1st of April, at this point now updating on the progress that the Crick had made supporting the national testing. You obviously referenced that email by saying on March the 19th, we informed 10 Downing Street through the Prime Minister's advisor, William Waugh, that the Crick had decided to turn significant institute resources over to PCR testing to help support the national COVID-19 testing effort. And the email was provided. And then you indicated the progress that had been made, that we're now in a position to scale up, starting with around 100 tests a day later this week, moving to 500 a day by next week. Subsequently, we are aiming for at least 2,000 a day. Our objective is to have results within 24 hours, as this will help return healthcare staff rapidly to the front line, which is our initial priority. In addition to the testing in the building, we've also many expert volunteers on standby to support public health to scale up their testing laboratories. And in response to that letter, did you have a response?
I don't recall a response, no.
Thank you. Now, if we turn over the page again, please, we can see that a further update was given from, this is actually internally in the Crick, from Sam Barrell to yourself, but attaching a document, which we then see on the next page, please, at page 11, which was a document that had been provided to the call that had taken place the day before with the Department of Health and Social Care, so on the 18th of May. Are you able to give any further details about that contact and input and the sharing of the opportunities to increase throughput in the testing pipeline document that we see that starts on page 11?
Yes, so we were now, and as you see, we're doing 2,000 a day tests. We were reporting that. We could increase to 4,000. We didn't have the resources, as I said, so we were using our research resources. But I think it was at this stage that we realized that we could go to 10,000 if we had the resources. I was a little surprised that nobody even contemplated giving us some support. And of course, nor, and you may get to that a bit later, was it being considered that what we were doing could be rolled out.
Thank you. And I'm going to just turn over the pages of this document because it's a detailed document. It had obviously been given a great deal of thought because it set out strategic, operational and specific testing issues within the document. We move over to page 13, please. Thank you. And on to 14. And into page 15, please. 16 and 17. And so the letter will be published. I don't have the time to deal with each aspect, but I think it speaks for itself as to things that have been identified, but solutions that the CRIC had found, but also the real benefit it was having on the ground locally for those that you were providing testing to.
Yes, and if I could just add, together with Sam Barrell, who was a COO, Sonia Gandhi and Charles Swanton were two of the three leaders who actually drove this on the ground. I just want to acknowledge them.
Thank you. Now, can we then just briefly on asymptomatic, turn to page 13, because we'll look together very briefly at an article that was published. So we go to page 13, please. We can see that within this letter it was identifying there appear to be no national PHE guidelines regarding the testing of asymptomatic healthcare workers, and referencing Sam Barrell speaking to Duncan Selby on the 20th of April with Charlie Swanton and Peter Ratcliffe, and discussed the importance of testing asymptomatic healthcare workers, as there is evidence to indicate that there are almost certainly a source of cross-infection.
This is a very important point, I think, for you. The asymptomatic healthcare workers who are dealing with vulnerable patients can, of course, spread the disease. Nobody knows they have the disease, but they could spread it. Now, there was ample evidence, actually, from the very early on with studies in China, Hong Kong, Italy, the cruise ship, that asymptomatic transfer of the virus from asymptomatic individuals was taking place. Now, once you realize that, then you realize you have a problem in a healthcare situation, because what that means is that you may well have healthcare workers looking after vulnerable patients who are spreading the disease to those vulnerable patients. So it becomes a very critical issue. What was happening at the time was that testing was only being made available to those healthcare workers who had symptoms. Now, that's a sensible start, because sometimes viruses are only spread from people who have symptoms. But there was really good evidence that that in this case of COVID, it was possible to spread it from people without symptoms. And this meant that you had to simply test all healthcare workers. Now, that wasn't happening, and I think it wasn't happening, and I'm guessing here, you may want to find out, but I suspect that the testing capability at this stage was simply could not test all healthcare workers. However, had they followed a month or two earlier what we were proposing with the CRIC out across the country, that would have been possible, because it was possible with the testing we were doing locally to the CRIC. So I do think this will have contributed to the spread of the virus amongst patients at this time as a consequence. And subsequently, of course, it became clear that there were indeed high levels of healthcare workers who definitely had the virus and were potentially spreading it.
Thank you. We'll look briefly in a moment at what the research had identified, and perhaps so we're clear, the testing that the CRIC provided into hospitals and the research that was being done had clearly identified that locally in London, asymptomatic transmission was taking place, because on the testing that the CRIC was doing of those healthcare workers in hospitals and care homes, there was clear evidence of asymptomatic people, but who were positive for COVID.
There's clear evidence confirming the earlier studies that I referred to.
Thank you. And then we've looked at May and the document provided to the DHSC, but I want to now deal with a letter we're going back in the chronology.
Yes.
But you've already, and it's your letter, please, 587060, which was the further letter on crick-headed paper. So we've looked together at the earlier letter in April, but we're now at the one that you, Dr. Barrell and Sir Peter Ratcliffe sent on the 14th of April, and this time directly addressed to the Secretary of State. And can you just confirm, was that the Secretary of State for Health, Mr. Hancock?
Correct, it was Matt Hancock, yes.
Thank you. And we'll look at the terms of the letter, because as well as identifying what you could do at the CRIC, would you agree that this letter clearly identified the concerns around asymptomatic healthcare workers and the need for asymptomatic testing?
It clearly identifies that as a major issue.
Now, we can see that the starting point for this letter was the evidence had been given to a select committee on the 6th of April, and it says as follows: we followed the committee's debate on the adequacy or otherwise of testing capacity within the NHS, but were surprised that, as far as we could hear, no mention was made in that assessment of the need to test asymptomatic or oligosymptomatic individuals. Pausing there, what's oligosymptomatic?
A limited number, in this context, limited numbers of symptoms.
Thank you. Be they healthcare workers or patients, this is of great concern in view of emerging evidence that a high proportion of infections are asymptomatic, obviously and training a high risk of transmission between and among healthcare workers and patients. We assume that this has already been debated amongst Her Majesty's Government advisers, and you might feel that appropriate responses have already been considered. However, there are several reasons for our concern and for writing to you directly in this way. These are as follows. 1. Our perception that at present there is reticence about doing more widespread testing of healthcare workers. It will clearly be expensive and yet another challenge for hospitals that are already under pressure. Some have privately expressed their concern that making a positive diagnosis in asymptomatic healthcare workers who might otherwise continue to work will deplete staffing levels at a time of need. Whilst perhaps understandable, these concerns are not productive in terms of the overall goal of controlling the epidemic. Rather, it will result in recurrent problems of seeding fresh outbreaks with staff absences and the potential for infecting non-COVID patients in the healthcare environment. Importantly, we consider that these concerns can only be overcome by a clear central directive from you as Minister. Is there anything else you want to expand? The terminology and what's being said seems pretty clear, but is there anything else you'd like to add, Sir Paul, to that?
I think it, frankly, couldn't be clearer.
The letter then goes on. The operational issues in setting up systems for systematic and repeated testing for healthcare workers are very substantial, even apart from the tests themselves. We are concerned that this may not have been fully appreciated. To avoid delays, it is essential that this is done in parallel with the development of testing capacity itself. Is there any expansion that you want to make to the point?
No, it just emphasises the importance of immediately increasing testing capacity, and as could have been done locally had the same model been followed.
You go on. The most accurate interpretation of testing results is only like to be achieved by systematic repeat testing in vulnerable groups. Such data collections will be essential for accurate assessment of whether and for how long a particular titer of antibody against a particular viral antigen is indicative of protective immunity.
Yes, it's a little bit more complicated, but it indicates the importance of correct interpretation of the data.
And it goes on, even when the current wave of the epidemic has passed, there will be a continuing risk of re-emergence with a strong likelihood that this may originate and be at its most damaging within the healthcare sector. So the need for systematic surveillance will be ongoing for the foreseeable future. We therefore advise you to action an initiative that all NHS trusts and healthcare providers should be required to set up surveillance systems for the regular testing, both virological and serological, of all healthcare workers and patients with immediate effect. Our concern is that if this is not done, the current initiative to expand testing itself will not achieve the desired effect, and the breathing space potentially achieved for the NHS by the lockdown will not have been used effectively.
Yes.
Now, we've looked at the chain of correspondence that had not had a substantive response. Did you receive a response to this letter of the 14th of April from the Secretary of State for Health?
We did receive a response in July, if I recall correctly, but it wasn't from the Secretary of State, it was from a civil servant.
Well, we can look together at that response, the July letter. I just wanted to clarify there was nothing before the letter of the 6th of July.
No, there was not.
Can I then have displayed, please, INQ 587061? Thank you. This is the letter that was sent on the 6th of July. The name of the individual, being a more junior individual, has been redacted. But would it be fair to say that one of the major issues being flagged was the issue of asymptomatic need for testing?
Yes, and I think I described this letter as anodyne, if I recall correctly.
Well, let's just look at the response that was given to the letter. Obviously, a thank you for the correspondence of the 14th of April to Mr Hancock, co-signed by Sir Peter Ratcliffe and Sir Paul Nurse, about the novel coronavirus. I've been asked to reply, and I apologise for the delay in doing so. I understand your concerns, and I hope these are now resolved. I trust the information below is helpful nonetheless. Testing is a key part of the UK's response to COVID-19, and following the publication of the government's strategy, capacity has rapidly expanded. Anyone in England who has symptoms of COVID-19, whatever their age, can now be tested for the virus. Further information can be found at various websites and about getting tested. Now, obviously, that's flagging the fact that anyone with symptoms can be tested, but you had flagged the concerning issue as to asymptomatic testing. I'm going to go to the next page because it allows the full context of the letter to be seen. Thank you. And it doesn't seem from my reading it that there was any addressing of the concern around asymptomatic transmission in healthcare workers or testing. Is that your reading of the letter?
That is my understanding. I think we also have to be disturbed by the fact that it took 3 months even to get this letter. I'm a yeast geneticist, so I could understand I was ignored. Peter Ratcliffe, as I said, is a very prominent clinical researcher. But for the Secretary of State to ignore a letter from 2 Nobel laureates in physiology or medicine for 3 months is a little surprising, I would say.
Thank you. Now, you've already commented upon what you believe would have been possible if local testing had been put in place sooner. Is there any additional evidence that you wish to say about your views about what should have been happening sooner in respect of it being clear and necessary for the view of the CRIC that there needed to be testing of healthcare staff even that didn't have symptoms?
It was absolutely clear that was essential. The fact it was not put in place was a limitation on testing capacity, because I suspect they felt they couldn't do it. And rather than acknowledge that they couldn't do it, because that would have indicated a mistake in their overall strategy, they remained silent upon it. But I will repeat, in my view at least, that had they rolled out in March, April, a copycat of the CRIC across many publicly funded research places, what we had been doing, I think they would have easily managed to get the capacity to do that, and I repeat, that would have led to protection of vulnerable patients.
You've referenced protection of vulnerable patients, but does the same principle apply also to protection of healthcare workers?
Also for them as well.
Thank you. Now, can I just ask some follow-up questions in the context of those letters and what had been identified? The concerns raised in your second letter did not seem to have been acted upon because it's been identified that asymptomatic testing was delayed until November of 2020. Did you ever receive a later response or any further input from anyone in the rest of that year in respect of the concerns that Crick had raised about asymptomatic transmission and testing?
No, I certainly didn't get any formal response. There were one or two informal situations in the media which may have been touched upon, but no formal response.
Thank you. Can I also ask you, you have noted within your evidence the prevailing policy in the July of 2020 of survey sampling level of testing healthcare facilities was preferred to systemic regular testing to address staffing shortfalls from COVID positive test results. Do you have any comment as to whether it's likely that survey sampling contributed to COVID spread in healthcare settings from transmission to healthcare worker to patients and vice versa?
I'm not an expert in this area, but I think it is likely.
Can I ask you whether you have any views as to whether the delay in testing healthcare workers with immediate effect, as recommended in your letter of the 14th of April 2020, contributed to increased spread and invariably deaths?
Again, I don't have data on it, and I'm not an epidemiologist, but I think that is likely. I should emphasize, I think it was probably recognized somewhere that that was the case, but they just simply didn't have the capacity to test, following the strategy of total investment in large central laboratories which were still not operating sufficiently effectively.
Thank you. Can I ask you also, given the Crick's research around asymptomatic transmission concerns that were raised in the April and the surge in cases that we know happened in the autumn of 2020, do you have any views as to whether the delay in systemic screening healthcare workers and asymptomatic testing may have played a role in the spike in COVID cases in the autumn and winter of 2020?
I don't have a view about that. It is possible, I suspect, but you need to talk to a real expert.
Thank you. And can I ask you, we know that you raised these issues with the government of the United Kingdom. Do you know whether the Crick made any similar approaches to the devolved nations' chief medical officers or scientific officers or their governments?
I don't think we did. I'm not absolutely certain of that, but I don't think we did.
Thank you. Can we then, just for the last portion of my evidence, just identify a number of the recommendations that you and the Crick have detailed within your witness statement? And can we display on the screen, please? It's INQ 587302, but it's the internal page 21, please. Thank you. We can see at paragraph 2.4, you set out recommendations. If we go to the bottom of that page, please, we can see you give the detail and underpinning evidence, but you and the Crick recommend that the United Kingdom should have a national stockpile of standardised reagents and or resilient domestic manufacturing capacity.
Yes, we have that in this at the bottom of the page there, 2.41. That has to be combined with what is further up, which is the establishment of a plan for local testing that could be implemented very rapidly. So those two things have to be combined together. We do need a stockpile, or at least national ability to produce rapidly, but that has to be combined with the second point of a network of local testing facilities, which is a bit further up the page.
Thank you. Can we then turn over the page, please? I'm afraid, Sir Paul, I'm dealing with the highlights in bold because of the time, just to capture them. We can see that you recommend that there should be a clear roadmap for the development of new assays in the early stages of a pandemic, bearing in mind there's likely to be restricted access to control standards and consumables, or a scheme for continual pre-evaluation of emerging technologies as scalable and fast testing platforms.
Yes, and I think this only requires planning. It requires planning of identifying where the resources are most needed. That would be, of course, hospitals, care homes and the like. And then just ensuring that you can put something in place with everything here with control standards and consumables all which could be planned beforehand. And this means you don't have to hold something in place which would be expensive, big laboratories. You simply have a plan for repurposing pre-existing facilities, pre-existing laboratories, and make sure that they have a plan that would allow it to be rapidly implemented. So I think that is all that's required. It wouldn't even cost very much.
Thank you. I'm going to summarise, to go through. You've also recommended that the government should maintain an up-to-date register of the nation's network of research and clinical laboratories where large amounts of equipment are housed and relevant expertise is available for rapid repurposing in the event of a pandemic. I think that speaks...
That's exactly the point I'm making. Thank you. Yeah.
There's the point about the reagents then, that you recommend there should be coordination of production of reagents and testing across the nation's network of research and clinical laboratories.
Exactly.
Over the page, please, an up-to-date register of staff training across all aspects of testing to be maintained.
Yes.
A prior planning for sample collection standardisation in a readily automatable format.
Which is important because often there's IT issues here and you just need to solve those up front.
You then make, the CRIC make recommendations of inspector data, namely that urgent action is required to develop common platforms for patient care and data management, procured, managed and integrated system-wide, not at individual trust body level.
Yes, clearly.
Over the page,
vital, yeah.
Over the page to page 24, please. That patient data has to be consolidated across platforms into a single platform record, which can be presented via application program interfaces to allow for key patient data to be shared with and updated by approved non-NHS organisations.
This is basically stating solve the IT problems up front.
Thank you. Then further you go that NHS must invest in technology professionals and skills development system-wide and dramatically reduce reliance on external contractors and restrictive managed service arrangements.
I think that's critical, and I want to add something else. What we were doing was almost an example of public duty, rather than simply relying on commercial organisations to produce these tests. And I think insufficient attention was paid to the public duty aspect here. People wanted to help. They volunteered to help. They weren't allowed to help because all that was being thought about were commercial solutions rather than exploiting the great opportunities we had with our publicly funded institutions.
Thank you. And then over the page, please, to 25. In the context of clinical testing, you recommend a pre-pandemic plan should include a list of favoured or approved sites for quick mobilisation to help prioritise distribution of limited test material, potentially scarce consumable resources, and rapid integration into the reporting system.
2 words, proper planning.
Thank you.
Everything in this inquiry comes back to proper planning, I'm afraid, Sir Paul.
Yes.
And just finally, for my purposes, Sir Paul, I know your statement deals with much wider issues, including a concern you had about what was being said by the government about the extent of testing and tests from a news night. Can you briefly address that before I take to
Yes, I would like to, because actually, first of all, we have to have some sympathy. This is a very difficult situation to deal with, very difficult to communicate quite complex things to the public. But the government did no favours to itself by trivialising communication. I mean, a particular thing that irritated me was the 100,000 tests by, I think, the end of April, that was being put up, and then when it wasn't reached, poor old Grant Shapps was put out to protect a claim that 100,000 had been reached, when in fact over half of them or thereabouts was actually in the post. And when that actually emerged, and I mean, it would, my 8-year-old grandsons would realise that's nonsense. I mean, when that emerged, it actually undermines the public confidence that if a government can say they are meeting 100,000 when 50,000 of them are in the post, what else are they meant to believe? This is where communications and PR is simply overwhelming truth and engagement and truthful communications with the public. I think it was outrageous.
Thank you. And then just to finally end the evidence, it seems right, you having identified the volunteers that gave of their time and expertise, could I briefly display INQ 587069, internal page 5? And the full article here essentially sets out in detail what the CRIC did and achieved. But if we look on the last page of this article, we can see there the CRIC COVID-19 consortium and the names of a great many of those that were part of the consortium that worked for the public good that you've described. And I think it's appropriate in my questions to end with displaying the names of those individuals.
I'd just like to acknowledge all my colleagues here who were working long shifts. No extra pay, of course, they were on furlough, but they did it, I repeat, out of a feeling of public duty.
Lady, those are my questions. There are questions from the call participants.
I think Mr. Thomas is first. Mr. Thomas is over there. So we'll...
Good morning, Sir Paul.
Good morning. Good morning.
I'm representing FEMHO, that's the Federation of Ethnic Minority Healthcare Organisations. Sir Paul, as we reflect on the response of the pandemic, I would like us to address the role of ethics, accountability and inclusion in the decisions that were made in and around the testing, in particular, trying to understand how equity was integrated into the design and implementation of the TTI system, especially how it impacted on marginalised communities. So with that in mind, my questions are aimed at trying to explore those issues. So the first question is this. So Paul, in your experience, with your insight into both the scientific and logistical barriers faced during the pandemic, how can we ensure that ethical and equity considerations are formally embedded into future pandemic testing protocols, particularly when addressing the needs of underserved communities?
I think I don't have any specific and special knowledge of this particular area, I have to admit, but I think it is very difficult to achieve equity unless you have the capability to deliver in this instance, the testing that was required. And in that situation, all communities will suffer, of course, but including marginalised communities. So what we see here is the failure to produce the appropriate testing, and we've just been discussing that. And as a consequence of that, communities will suffer, including marginalised communities. So we need the capability, in short.
Well, that leads me on to my second question, which is, if you can assist us, who in your view should be held accountable for ensuring that these ethical and equitable considerations are adhered to, particularly when designing the testing, especially when it comes to safeguarding the interests of marginalised and minority ethnic communities?
I think what's critical here, as in all times of crisis, is proper political leadership. Leadership which leads to the confidence of the nation and all parts of the nation that the very best is being done to deliver an appropriate outcome. So the key issue for me is good political leadership. It is not enough to simply say, for example, we will identify a company who will do it and put it off to somebody else and not take responsibility for actually getting a proper delivery of the appropriate outcome.
Thank you. As we reflect on the systemic failures of the TTI system, particularly in respect to minority ethnic communities, how do you assess the role of cultural competence in the initial design and implementation of these services?
I think critical here, and I'm not sure I'm fully addressing your question, is appropriate communication of all aspects of the issues around these particular problems and deliveries. And I think why I emphasize communication is that those who come from different communities have different needs for appropriate communication, and you have to make sure that the communication, which is critical, is actually tailored in such a way that it is appropriate to all parts of the community. I think that would be the only comment I could make about it.
Communication being key.
Yeah.
And finally, this is my final question. Looking back, what could have been done to ensure that the TTI system was both culturally competent and equitable in its outreach and provision of services, especially for vulnerable and at-risk communities?
I think it's having people in charge who care.
Milady, thank you.
Thank you, Mr. Thomas. Miss Munro. Miss Munro is there, Sir Paul.
Good morning, my lady. Good morning, Sir Paul. My name is Alison Munro. I ask questions on behalf of the COVID Bereaved Families for Justice. Sir Paul, thank you for your evidence this morning. Just 2 questions on behalf of our families that we would welcome your views on. Both in your oral evidence and indeed in your written evidence, you've emphasised that key workers, both symptomatic and asymptomatic, should have been the focus of early testing and especially healthcare workers. My question is this. Notwithstanding the high infection and mortality rates of TFL workers, in the first wave, they were not prioritised for COVID testing following the government's suspension of community testing on the 13th of March 2020. In your view, should TFL workers and other key workers such as teachers and domiciliary workers have been prioritised for testing as were the healthcare workers?
So what I think here is that we need to look at our at the community across the board in our appropriate planning. And I said proper planning a few minutes ago, because you're quite right. There are a variety of different key workers, not just healthcare. We emphasise healthcare because of the spreading in amongst vulnerable patients. But there are others which should have a protected status. I want to emphasise something that we haven't mentioned. We managed, of course, to protect the CRIC by testing individuals at the CRIC. And this meant that we allowed people to do research into COVID in the CRIC. Now, the principle you're talking about there applies to other essential activities and different workers that you've mentioned. This needs proper planning as to where you need the testing and to make sure you have the capability of doing the testing through the sorts of, in my view, the sorts of recommendations that we've made to mimic the CRIC in any future pandemic.
Thank you, Sir Paul. And my second and final question, to an extent you have answered it in answer to Mr. Thomas King's counsel. But, Sir Paul, you note that the CRIC consortium was staffed by volunteers, as you say, who otherwise would have been furloughed. And at the outset, the testing was focusing on NHS staff and families. But the work from the CRIC later included collaboration with clinicians at UCL, H and other hospitals, local hospitals, and programmes to test, for example, homeless individuals, residents and staff at care homes locally, and staff and users of mental health units. So looking at those particular vulnerable groups in society, would you agree that that outreach testing, such as was carried out by the CRIC and its partners, was perhaps more suited than digital apps for certain vulnerable groups within the population, such as the mentally unwell, those with mental disabilities, elderly, and those who are unsupported and unable perhaps to be, for want of a better word, less digitally literate?
Yes, I'm no expert in this area. As I said, I'm a yeast biologist. But there's no doubt, I think, that when you have an initiative that is local, by its very nature, that will focus on the needs of the local environment, which I have a feeling will include exactly the sorts of things and people that you mentioned. We got a lot of advice back and a lot of proposals back from the community about where testing should be applied, and we did our best to actually satisfy it when it's requested. I think this naturally comes from more local testing by its very nature.
Thank you very much, Sir Paul. Thank you, my lady.
Thank you very much, Ms Munro. That completes all the questions we have for you, Sir Paul. I'm sure I'm not the only one who, when we heard just part of your CV, I felt extremely humble. So thank you very much to you and to your colleagues for all that you did and tried to do to protect people during the pandemic. Obviously, I can't reach any conclusions until I have heard all the evidence, but I have to say I share your astonishment that when 2 Nobel laureates write to important people that you don't get a response. Makes one wonder if they realised who you were, but it's on the letter, in fact, I think.
I think it was on the letter, yes.
Thank you again for what you did during the pandemic, and also thank you for your help to the inquiry.
Thank you for listening to me. Thank you.
Very well, I shall return at 25 to.
Thank you.
All right. Ms Cartwright.
My lady, please could Professor McNally be sworn?
Okay, if you'd like to repeat after me, I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Please.
I hope we told you you weren't first on, Professor.
Yes.
Thank you.
Could you please tell the inquirer your full name?
Yes, my name's Alan McNally.
Thank you. Professor McNally, you provided a witness statement to the inquiry. It's 31 pages. Could we go to page 31, where we see the date of your statement being the 27th of March of this year? And can I ask you to confirm that the contents of your statement are true to the best of your knowledge and belief?
I can confirm they are true.
Thank you. Professor McNally, could we together identify your relevant knowledge, experience and expertise? It's right, isn't it, that you are Professor of Microbial Evolutionary Genomics and inaugural head of the School of Infection, Inflammation and Immunology in the College of Medicine and Health at the University of Birmingham?
I am, yes.
And can you assist us as to how long you have been a professor at the University of Birmingham, please?
I've been a professor since 2019. I've been at the university since 2016.
Thank you. And I think, is it right that before that time you were formerly at Nottingham Trent University?
Yes, I was, yes.
Thank you. It's right, isn't it, that you are also a consultant for Prenetics?
Yes, I was. I acted as a consultant to advise them on their testing to resume the Football Premier League.
Thank you. You're also a trustee and member of council of the Microbiology Society.
I am, yes.
And it's right, isn't it, also that you have collaborated and contributed to the microbiology statement authored by Peter Cotgreve?
Yes, I did.
Also have.
Yes.
Thank you. And significantly, we're going to come on to deal with the fact that you were part of the team that set up the Milton Keynes Lighthouse Laboratory in March of 2020.
Yes, I was, yes.
And I think also of significance that we'll come on to deal with in a minute, that you have previously done postdoctoral research at what was VLA, now the Animal Plant Health Agency in Surrey.
Yes, I did. I performed postdoctoral research on avian influenza and diagnostics for that virus.
Thank you. Now, can we first of all identify, it may be obvious from your qualifications, but it's right, isn't it, you have a wealth of relevant experience that is pertinent to test, trace and isolate?
I think so, yes. Certainly from my postdoctoral work on avian influenza, I've also had several funded projects to develop rapid diagnostic tests over the years. Most of my research now is actually not relevant to that, but I do have, and also at the time of the pandemic, I was the head of one of the most prestigious microbiology institutes in the country, so had quite a bit of insight to give, I felt.
Thank you. Now, I'm going to start, please, with you looking at the beginning of January of 2020. And can I ask for your assessment at that time about what you thought was likely going to happen and what was needed?
Yes, I think myself and many other sort of senior microbiology colleagues across the country were watching what was happening in China. I also have very close collaborators in China that I was speaking to, and it was clear that this wasn't going to be a localized outbreak of respiratory disease. It looked like it had the potential to be a pandemic, and then as it spread into Iran, Italy, other parts of Southeast Asia. I think my colleagues and I were all discussing the absolute probability that this was going to be a significant pandemic. And then from my own expertise, the thing I started to worry about was whether or not we as a country would be able to cope with the influx of that disease, particularly around diagnostics and testing.
Thank you. Can we together just identify what ability the University of Birmingham had in January of 2020 to make PCR tests, please?
Yes, so as January unfolded, myself and some colleagues in the university, Professor Andrew Beggs, Professor Alex Richter, working with our head of college, Professor David Adams, we started to think about how we might contribute to efforts to control the virus, and that was specifically around testing.
I'm just going to ask you to slightly slow down for the stenographer, but thank you, continue.
So we looked at the equipment that we had in the medical school of the university. We had sufficient PCR machines, maybe around a dozen. We had containment level 3 facilities, which we could employ to help. And we had sufficient expertise and know-how to perform testing. Unlike Sir Paul, who was on previously, we don't have a core research budget that we could divert to. But what we did was have everything set up. We identified staff that we could train and who could help. And we got ourselves in a position where we felt we could very quickly redeploy efforts to offer somewhere between 3,000 and 5,000 PCR tests per day if it was needed.
Thank you. So that's 3,000 to 5,000 tests per day at the University of Birmingham. From what time period? Would it have been possible in the January?
Probably planning in January, with us being able to do that from mid-February.
Thank you. Can I perhaps explore what may be an obvious point, but the University of Birmingham and your medical school, does it have a direct sharing of data through hospital records because of the nature of the medical school?
Yes, it's one of the benefits that we have as a medical school is we have some research laboratories, and we also have some sort of semi-research, semi-service laboratories which already perform tests for the NHS and therefore report those results into the NHS data reporting system. So that's the major hurdle for university labs in being able to offer diagnostic testing, but most medical schools have labs that do that, and therefore that obstacle does not exist.
Thank you. And so again, in terms of what was possible in February of 2020, would it be local testing at the university using the university laboratory, but also the ability that the data across and the recording of that positive or negative test could have been directly inputted into medical records?
Yes, we believe so. Yes.
Thank you. Now, we've just touched upon one medical school at one university in the United Kingdom. Are you able to assist us as to how many medical schools and similar calibre universities have a similar type of resource in the United Kingdom in January 2020?
Yes, it's a guesstimation. It's not an accurate summary. It's a guesstimation. But there are around 40 medical schools in the United Kingdom, so that's across England, Wales, Scotland, Northern Ireland. All of the vast majority of those are research-intensive universities. They would have the equipment, the expertise, the staff, and the vast majority of them would already be doing research projects that would allow them to share data with the local NHS trusts.
Thank you. So the same data sharing ability and flexibility
Yes.
of testing, inputting and records.
Yes.
Now that's the mainstay medical schools in the United Kingdom, but is there a different cohort of universities that also have the laboratory centres and the laboratory equipment that aren't the classical core 40 medical schools? Please?
Yes, absolutely. There are research universities, pockets of research intensivity in universities up and down the country. So you could easily add another 30 or 40 laboratories that had the equipment and the know-how that could have contributed. They probably would not have that normal day-to-day seamless exchange of data with NHS, but that would be the only obstacle to them also standing up and supporting.
But certainly having the correct PCR equipment, the relevant expertise,
Yes.
and ability to perform testing quickly.
Yes.
Now, in terms of other existing infrastructure that existed in the United Kingdom, I highlighted when I dealt with your past experience, the Animal Plant Health Agency.
Yes.
The inquiry's already heard some evidence about zoonotic diseases and viruses. Can you assist with your informed knowledge about what laboratory structures and availability existed through the Animal Plant Health Agency, please?
I would argue that the APHA, the Animal Plant Health Agency lab in Weybridge, and the large virology research lab in Pirbright were almost certainly the two facilities that would have needed absolutely zero support in beginning COVID testing immediately. The APHA was a European reference lab for avian influenza, for rabies virus, for lots of different viruses. So it's already performing diagnostic tests at the very highest level, the same PCR test for viruses. Similarly with Pirbright. And there are other facilities like the National Institute for Biological Standards in Hertfordshire. You know, they're doing testing for high containment level pathogens on a regular basis.
Thank you. And I've sought your help to try and understand infrastructure. On top of that, can you assist just so we've got a proper context of your informed view about what existed? And you touch upon it in your statement, but it's just to make sure that there's no confusion about what existed. We've heard about the virology network and the virology laboratories.
Yes.
Can you just assist as to where they sat? And obviously that's quite separate as to how that then factors into what was available.
Yes, so those are the network of, if you like, hospital-based laboratories that have the infrastructure, expertise and equipment to perform relatively high throughput molecular test, PCR testing for viruses. They were part of the old Public Health England network of labs, around about 40 or so. As the pandemic emerged, 12 of those were stood up to provide testing for the UK, but there is that network. And then there's also further clinical microbiology labs with PCR machines and obviously the expertise to turn over to viral PCR testing.
Thank you. So just to be clear, and I dealt in my opening with the fact when PHE commissioned 12 of the PHE labs, your evidence and knowledge is that sitting outside that there are other PHE laboratories that also could have been stood up for testing.
And clinical microbiology laboratories.
Thank you. And then separately again, in terms of laboratories that existed in hospitals up and down the country, are you able to assist at all as to how many laboratories they would have had also additionally? I know a lot of their testing would have been contributing to the effort, but again, just to get an idea about existing infrastructure.
Yeah, I can't give you I can't give you a fully informed answer to that. Many laboratories, as hospital labs and public health labs were rejigged pre-pandemic, many of them became a hub and spoke model. So an example I gave you when that happened, I was in Nottingham, is that a hospital like Chesterfield reduced its capability to do PCR testing, but would have used Nottingham as a central hub in order to do that type of testing. But the majority of hospital laboratories are able to do a PCR test. Many of them have now moved over to black box cartridge systems, but there are dozens and dozens of labs that can do PCR testing for viruses.
Now, other than being able to tell us what you think was achievable on a daily basis in Birmingham, I'm not going to ask you to even attempt to estimate, but can you just solidify again what you say would have been possible in Birmingham in February?
In Birmingham, again, by mid-February, I think we could have run 3,500 to 5,000 tests per day. And speaking to colleagues in other medical schools, Leeds, Nottingham, they were seeing identical things. They could have stood up to 3,500, 5,000 tests per day. So 40 medical school labs, 5,000 tests per day each is 200,000 tests.
Thank you. And now, we know that, in fact, you started to take steps with the view to thinking that was exactly what you would be doing on the ground in Birmingham.
Yes. I've been doing a lot of press work in my prominent microbiological role. I've been doing a lot of press work suggesting that we weren't prepared for the level of testing that would be required to stay ahead of the virus. And that had led to a lot of conversations with colleagues across the country, and that's where we started to look at exactly what we could do. And as I say, we'd started to localise equipment in a number of labs that were better suited if we were doing proper diagnostic testing. For example, one of the labs, the Clinical Immunology Service lab, which has already feeds data into the NHS. So we were being very strategic about where we were placing resources. We were starting to identify staff that could be trained or were already trained and that could help us with the testing. Some of them were starting to be furloughed and so on. So we had what we felt everything in place. We turned the containment level 3 labs over to complete, just would be used for that purposes if needed. As I said, unlike Sir Paul, we don't have a core research budget, so we weren't able to actually start any testing, but we felt we were in a position where we had everything ready to go if the support was given to us to start.
Thank you. And can I ask you, you've just said that you didn't have any specific budget as a university. The inquiry's already heard some evidence about the successes in Germany.
Yes.
And what Germany was able to do.
Yes.
And can I ask you, in terms of how Germany's universities are utilised, whether there's any relevant evidence you have about the funding of Germany universities?
Yes. I mean, this is the point I was making the whole of January and February, is that in Germany they have a rather wonderful system. It's a federated lab system where they use a mixture of university laboratories, commercial laboratories, veterinary diagnostic laboratories, and essentially what they do is they apply to be part of that network. They're then sent some samples to test to check if they're up to the job. They have staff that are trained and on a register of staff that can do that testing if required. And they essentially sit on standby, ready to completely divert their activities to diagnostic testing if it's required, which is why Germany was able to start testing in January, February of 2020. The cost of that, again, this is a guesstimate, a very back-of-the-envelope calculation on my behalf would be £500,000 per lab per year to sustain that. 20 labs, you're looking at maybe a £10–15 million per year budget for that to be sustained.
And so the government of Germany, as part of this scheme, invests that proportion of money into the universities that are able to essentially have that facility ready to devote to testing.
Yes, and it's controlled by state, basically the state infectious disease lab, the Robert Koch Institute, so they have overall responsibility for it and they maintain it and oversee it.
Thank you. Now, I am going to ask you this question because I know that you were involved in the setup of the Milton Keynes Lighthouse Lab. So you've contextualised the £10–15 million annual figure in Germany for that facility at the universities. Can you contrast that with how much it cost for the initial setup of the Milton Keynes Lighthouse Lab, please?
Yeah, I mean, I must stress I do not have anything in writing, but you know, you're talking a facility, the number I heard was somewhere in the region of £150 million to establish the Milton Keynes Lab.
And can you assist as to what time frame that you've been shared that information of £150 million?
That was over the first 3 months when I was there to help set it up.
And I think we'll perhaps come on to deal with together that essentially the Lighthouse Laboratory network has completely gone and been mothballed.
Yes, it's a bit of a tragedy that none of it exists anymore. The equipment was sold off. And the staff have all returned back to what they do, and there is nothing remaining of the Lighthouse Lab network.
Thank you. Now, I'm going to please take you to... Well, actually, before I do that, I just like your views. You were plainly watching what was emerging in January and February, giving thought about what was possible. And so I'd like your views with the relevant expertise you do have as to if that resource was stood up in February of 2020, what that could have meant for stopping or reducing, mitigating the pandemic. And assess it if you're able, if you're not equal.
No, I think I can answer that. I think, as Sir Paul said earlier, I think we needed the large lab network, the Lighthouse Lab network, because at some point you are going to have to perform 250, 500,000 tests per day. And so we needed those large central labs. But I believe in January, February, March, university labs, research institute labs could have been stood up in a couple of weeks. And that would have created that sort of holding capacity of tests such that you could have slowed the growth of transmission and the growth of the pandemic in the early part of 2020. It would not have stopped the pandemic from happening, but it could certainly have slowed the rate at which it happened. That would have alleviated the pressure on our healthcare system, and it would have put us in a much more informed path of how the virus was coming into the UK, how it was spreading, hotspot areas, for example, that we might want to invest testing in, such as healthcare facilities. Places like, as an example, in Birmingham, there was an abattoir that saw a massive outbreak, largely driven by migrant workers. Having a good early testing infrastructure could have allowed us to very quickly identify hotspots of transmission and get slightly ahead of the virus.
Now, could I ask if you can assist me, please, Professor McNally? We know that the national position across the 4 nations on the 12th of March 2020 was to stop all community testing and to stop contact tracing. And it appears that part of the reason for that was the lack of testing. Do you have any views on that decision informed by the evidence you've just given about just what was possible in February, please?
I think I'm on record in the press as saying I was flabbergasted. I just can't believe that decision was taken.
Can we then please, I think we see some similarly strong language in one of the emails from the 19th of March. I'm going to take you there now, please. And I don't do it for embarrassing. In fact, I'll skip over the word. But if we could go, please, to INQ 582851, please. And it's, I'm afraid, on the chain, we're going to have to move to the next page because it works backwards. So let's start at page 2, please. Thank you. And I think we see here the decisions that are being made and what was being asked, and we'll come on to then what you've been doing. So this is a letter that's been sent, but essentially been sent on behalf of Jeremy Farrar, is that correct?
Yes, to all medical schools across the country.
I'm going to read it. Dear all, excuse the late hour and an extraordinary request. And so this is 4:46 on the 19th of March. You'll be very aware of the COVID-19 pandemic and the inevitable impact on the United Kingdom. We have been working 24 hours, 24/7 over a number of weeks now on this, and over the last 2 days have been focused on increasing the UK's capacity for diagnostic testing, healthcare worker, individual patients in hospitals, people at home, and age-stratified population serology. It's clear that whilst the NHS and PHE are ramping up, there's no way they can meet the surge that is going to be needed. We estimate that we will potentially need to get to 200,000 to 300,000 tests a day at the peak of this pandemic. Current capacity is, I think that means less than 5,000 tests a day. Not only do we have to increase the number of tests, but also the speed of getting those tests completed from sampling to assays to results fed back to people, all the logistics being done at scale and at speed by professional companies used to dealing with such complex issues. And there's a reference to the individual. Amazon has been a great partner through this, and this comes with a very strong support from across government as the only viable solution, so the extraordinary request. Pausing there, can I ask your comment? It may be obvious from the evidence I've already given, but is what was being asked and proposed in this email the only viable solution?
I don't agree with that, and I made it quite clear throughout January and February that I believed university labs and research institute labs could have been utilised.
And I rather suspect that after this email, the university network themselves shared their own views about it.
Yes.
And
yes.
Sorry, and again, if you're able, was there any consensus view that fitted with your view about this being the only viable solution?
All of the colleagues I spoke to, as I said, this email was received by all medical schools. All of the colleagues I spoke to in the prevailing 24 hours said the same, that it was a solution, it wasn't the only solution. Universities were ready and willing to step up.
Let's read on. The best approach is to use, in the first instance, is to use the Thermo Fisher platform. Others, Roche, how do you pronounce that? Sorry.
QIAGEN.
QIAGEN, thank you so much. And others will follow. and to use these in dedicated diagnostic factories in the UK, probably 3 in the first instance, with dedicated equipment staff and able to work 18 to 24 hours a day, 7 days a week. There are no Thermo Fisher machines to buy globally or any other platform. Many of your universities and institutes have these machines. We want to ask you to work with us, all at this time a great national need to allow the machines in your universities and institutes to be provided to the centralised diagnostic centres and to do so urgently. We appreciate there are a significant number of issues to work through, QA, QC, regulation, ownership, replacement, equipment when we eventually get through this, liability and many more. But these are unprecedented times and we cannot use binormal processes. With the UK now on the cusp of the epidemic following the path of Northern Italy, and with the doubling time in parts of UK now of 3 to 5 days, currently this could not be more urgent. We estimate that ITUs will be beyond capacity within 14 to 28 days. If the measures announced over the last week fail to shift the epidemic curve, we all at Wellcome have been working on this with Number 10, CSO, CMO, DHSC, the Office of Life Sciences, Amazon, Thermo Fisher, Roche, Cregan and others over the last 36 hours, and are a totally committed partner to this national and global emergency. We need your help. Tomorrow the Prime Minister will write to you and add to this request, but I wanted to give you a heads up tonight. In an ideal world, the Army would pick these machines up in the next 24 hours. That is the sense we believe of the urgency. Much to think through and ponder, and we may not have all the answers today or tomorrow, but we hugely appreciate your partnership and urgent support. Very best wishes, Jeremy. And so if we go back to page 1, please. And again, we see a chain, but we see your response at 5:24. Wow, I didn't see that coming. And if you can excuse the French, that's a massive fuck you to the whole of UK academia. It's not the direction of travel I was sensing. The most senior of PHE colleagues were telling me the use of uni labs for community testing was almost certainly going to happen. I was on 5 Live this afternoon recommending it. We should, of course, try and fight our corner, but this feels like an absolute done deal. All testing will be in approved, validated, accredited labs. Real shame. Professor McNally, does your email effectively capture your complete sense of shock with the decision that was then being communicated on the 19th of March?
Perhaps rather too clearly, yes.
And then can I ask you, the practical thing that was being asked was essentially all of these universities that had the equipment, had staff that lived nearby that could operate the equipment, had the knowledge and expertise. The machines were being taken from where they could be used locally and placed in what was perceived to be needed to be created a factory that didn't exist at that time.
Yes.
And be placed there.
Yes. And then subsequently to this, a request if we could provide staff to voluntarily staff the labs as well.
And we know that you did and you went. But can I ask you perhaps to use heard some evidence of a witness in this inquiry. Hazel Gray talked about common sense. Have you any views on when you had an existing infrastructure that was ready to go, of removing the equipment from the institute that could start making these tests, essentially reconditioning it and taking it away for national effort?
It made no sense to me and to other medical school colleagues I spoke to. It made no sense. A lot of them were very, very angry by that letter from Jeremy Farrar. It didn't really make any sense to me at all.
And is that what happened? Did all of the University of Birmingham's PCR machines get placed into the Lighthouse network?
So actually later in this chain you can see that there was an agreement that we could keep some of our PCR machines because we were in a position where we could help the local hospital and local public health. We did provide equipment though. The Army came and picked up quite a substantial amount of equipment from our university the next day and from universities all across the country. The Army handled the logistics of picking those pieces of machinery up and transporting them.
Thank you. And we know that was what happened in terms of the proportions going. But can I ask you just from a logistical point of view, I think you'll probably know, if you move a PCR machine from Birmingham to Milton Keynes, how quickly can you then set it up in Milton Keynes?
In terms of the machines, fairly quickly, they have to be checked and recalibrated because they're very sensitive machines, and in movement, some things can need tweaked after that. The actual machines themselves fairly quickly, but of course it's all the other parts of the testing, installing safety cabinets, finding staff, and then creating your SOPs, your workflows, which rooms are you going to do things in, and so on. So there's a substantial piece of work still needs to be done at the stage after the equipment arriving in the laboratories.
But can I ask you then, is thought could have been given to allowing the PCR machines to stay where they were so universities could continue to use them until the infrastructure in the Lighthouse Laboratory said we're ready for it, and then it could have been moved in a short period of time with the assistance of the military?
Yes, potentially, yes. Or the kind of halfway house that we reached at Birmingham, where we provided some equipment, but not all of our equipment, and we kept some of our equipment.
Thank you. And then can we look at the Pro-Vice-Chancellor's response? And it's please INQ 585205. Page 1, thank you. We can see that the response that went back was, Dear Jeremy, I've just received your request to set up testing factories using university capabilities and machines via MSc. Over the last 3 days, our researchers here, led by Alan McNally, have worked closely with PHE and our NHS partners to set up testing in our university laboratories. We have capacity for more than 10,000 extra tests per day already set up, with 35 academic volunteers who can work on a rota to provide the testing. We are hoping to more than double this by bringing aboard our regional genetics lab. It would seem a shame to stand people down and relocate facilities centrally, but maybe we can act as local hub as part of your greater scheme. And so obviously you're being referenced to the great efforts that you had made. And can I just get an understanding, is if this request had not been made for the machines, when would you have been, the extra things that you were putting in place have been put to use?
It was my colleague Andrew Beggs, actually, who was really driving that effort. I was providing the oversight of it, but yeah, I mean, Andrew runs a cancer and disease genetics lab. He believed he was in a position where they could have went live in a couple of days.
Okay. Now, in terms of then, we know that you then, following requests, went to assist in setting up the Lighthouse Laboratory at Milton Keynes. Yes. And can you just help us then with plainly the shock when the pivot, as detailed in that email, happened? And so can you give some idea to her ladyship why then you followed the request to go and set up the Lighthouse Lab at Milton Keynes, please?
I think it was, as I said in the email, it was a done deal. And we'd lost the fight. We weren't going to be doing testing in university labs. Then personally came to a question of, can I still help? And lots of academic colleagues felt that as well. And so I was asked if I could find some volunteers from Birmingham to staff the lab in Milton Keynes. I sent an email round to the university, collated quite a substantial list of names, added my name to the top of that list and sent it forward as these are people that are willing to come and help. I wanted to do something, and I wasn't going to be doing anything in the university, so that was the not quite as great option, but the next best option, I felt.
Thank you. Then can we just, well, perhaps rather than needing the emails, can we just do it? So I think it's right, isn't it, that there were requests for you to participate in calls with, was it Ms. John Bell and Deloitte?
Mr. John Bell, yes.
John Bell, sorry.
Representatives from Deloitte, yes.
Or perhaps can I allow you, rather than me taking you to documents, just to give an idea to your ladyship as to then who you spoke to, who was involved in the discussions after the 19th of March that then takes you to Milton Keynes?
Yes, primarily it was an email inviting me to an online call. So John Bell was there, some senior representatives from Deloitte, some people from Wellcome, and some people from the Office for Life Science at Number 10, where they made clear to us that plans were very advanced and in place for a small number of centralised labs, including a lab in Milton Keynes. The argument that was given was that would make it easier to basically focus all of the reagents and plasticware required to do that sheer amount of tests in one place, so it made it easier rather than transporting them around the country, and samples, transporting them to a small number of places. And that was going to happen, and that was all there was to it. And we could continue to try and help in Birmingham if we liked around healthcare workers and with local public health teams, but that was how national testing was going to work. I then received a number, I was asked if I could find some volunteers to staff the lab, which I did. And then I received a phone call on my mobile phone from, I'm not quite sure who it was. I was under the impression it was someone from government.
Professor McNally, can I just ask you to
slow
down just a little? Thank you.
Asking if I would go to Milton Keynes the next day and help set up the lab. So I had a brief chat with my wife and family and phoned back and said I would be in Milton Keynes the next morning, and arrived at Milton Keynes with 11 other people the next morning to start setting the lab up.
Thank you. Obviously that was a big personal sacrifice for you and your family to essentially uproot yourself from home to locate yourself in Milton Keynes. And obviously you managed to encourage 11 of those at the university to follow you also.
Yes, and then over the subsequent weeks and months, the Microbiology Society put out a larger call for people to volunteer to help. The Animal Plant Health Agency was contacted, and they seconded quite a lot of staff as well. So, yeah, we very quickly went from a small number of staff to around about 240 staff. I would say of that 240, around about 200 to 210 were probably there on a voluntary basis.
Thank you. And let's just, on a voluntary basis, not being paid in respect to the work in the Lighthouse Laboratory other than furloughed salaries through the university?
Exactly. From a personal level, I was still being paid by the university, so I didn't see any need to seek recompense. I believe the Animal Plant Health Agency staff were still being fully paid as agency staff, and they were seconded on a voluntary basis as well. The vast majority of staff were actually postdoctoral researchers and research fellows who had been furloughed, who their labs had been closed, they couldn't do their research, and they put their hand up to voluntarily come and work in the lab.
Thank you. And so then, can you give us an impression then as to what was at Milton Keynes when you got there? And let's crystallise the date. What date did you go to Milton Keynes?
March 27th was my first day there.
Thank you.
Was it? Yes, then 27th, yes.
And can you then assist us? Because we've got the benefit through you of a direct lived experience about what was there, what existed, but the efforts that you took to set up the National Laboratory, please.
Yeah, so when I arrived that day, there was a small delegation from University of Oxford there. That was led by Dr. Mike Hill and Dr. Stuart Moffat. And a small number of their teams. So they'd already set up some protocols, some workflows for how they were going to do the testing. There was a very small lab set up with 3 or 4 safety cabinets where samples could be processed. There were a lot of PCR machines already there, and a lot of machines for extracting the RNA from samples, as Sir Paul mentioned earlier. So lots of equipment, very, very few staff, and I would say the early stages of some protocols, but only the very early stages. So over the next couple of weeks, Dr. Hill very quickly realised that I was a fairly senior microbiologist. He asked me to help him creating protocols, workflows. More staff were coming in on a daily basis. We had to then create a system whereby we could train those people as they came in, carefully train them, supervise them, and then sign them off as competent so they could start to help. And we got a rolling process of training and competence set up. And within a month, as I say, we had 240 people, and we went from 500 tests a day to, at the end of April, 30,000 tests per day.
And I think you've helpfully dealt with that chronology. So for the period of March the 27th to March the 31st, you identify the 500 samples per day.
Yes, yes.
On the April the 1st, you indicate that I think 600 tests were performed. 1 week later, 1,200 tests per day. And you then tell us that April 28th was when you performed 28,000 tests in 24 hours.
Yes.
And then on the 3rd of May, you achieved what was at that time your operational maximum of 30,000 tests in 24 hours.
Yes.
Can I just interrupt for a second? Going back to the point you're making about not using your labs in medical schools that were all set up and ready to go, had that policy been adapted at the same time as you say we did need the big labs,
Yes.
when would you have seen the transfer of skills of your staff and the machines to have the optimum effect on the small ships and the big ships, as Sir Paul called them?
It's an excellent question. I would suggest that, I think I've said in my statement, I think Milton Keynes and the other lighthouse labs were set up just a little bit too late to impact wave 1 of the pandemic. I think that the small ships idea would have been sufficient to slow down wave 1, help not overwhelm the health system, and have given us spring into summer to take our time to get the lighthouse labs set up, ready for what was undoubtedly going to be a much larger wave as we went into autumn and winter, as you would expect with the respiratory disease.
Sorry, just to pursue the point. It was only because of the equipment that the lighthouse that Milton Keynes had and the skills of the likes of you
Yes.
and the other people you were leading. But by the end of April, you've got up to 30,000 tests a day. Now, if that's replicated around the country, that's a lot of tests
Yes.
a day. But if you've kept the staff and the equipment in the medical schools,
Yes.
you wouldn't have got to 30,000 a day at the lighthouse labs, would you, by the end of April?
Not at the lighthouse labs, no. But what we would have got, I guesstimated earlier, I think you could have got to over 100,000 tests a day using that armada of small boats. And there were plenty of trained scientists to go around to staff those labs in hospital, in medical schools, as well as find trained, competent staff to staff the lighthouse labs, like the Animal Plant Health Agency staff, for example, and lots of other university research staff who were furloughed and who were more than capable of helping. There is no shortage of skilled staff at all.
Thank you.
Can we then perhaps just to look at the point of her ladyship a little more, look at the map of the lighthouse laboratories that gives a top line of when they were able to operate. It's INQ 587, 456. Now, obviously, the different lighthouse laboratories had different operators, so this really is top line, but it's significant because it assists with when various laboratories were opened. And so we know we can see, obviously, the Milton Keynes Lighthouse Laboratory, where you went and helped set it up, operating from April 2020.
Yes.
We have Alderley Park in Cheshire set up, and also Glasgow in April 2020.
Yes.
But looking at the Lighthouse Laboratory Network, that is it in April 2020.
And Cambridge as well. Cambridge used AstraZeneca's, the company AstraZeneca's lab facilities.
Thank you so much. But then if we look then and follow it through with the timing it took to bring the other Lighthouse laboratories online, we can see that obviously it continued to develop, but obviously, again, significant delays of months to establish them in 2020 through to 2021. So I think we've got Newport in October 2020.
Yes, so the expansion of Newport and Loughborough, that occurred at the time where the Lighthouse network was expanded, and the University of Birmingham had a lab incorporated into that. So those came online as part of that expansion programme for autumn-winter of 2020. The labs in 2021, they came in as part of there was a re-tendering process for Lighthouse labs. They came in as new labs in the spring of 2021.
Thank you. So you've already identified, so Charnwood in Loughborough in November 2020. We've then got Brantsbridge in Bracknell in March of 2021, and Baltic Park in Gateshead in March 2021, and Plymouth. And then we've got the Rosalind Franklin Leamington Spa Mega Lighthouse Lab.
Yes.
In June of 2021. Thank you. Now, I think you've already headlined alongside the laboratories that then opened in the October-November, that fitted with when you'd gone back to Birmingham and
Yes.
assistants you had then. But before we deal with that next bit on the chronology, are you able to give any other reflections or comments to Her Ladyship on anything that you identified in the setup of the Lighthouse Laboratory that you were central to, or any relevant evidence you'd wish to give? Obviously, there's a lot more detail in your statement, but if there's anything of relevance that you wish to particularly draw to Her Ladyship's attention, please.
I think the only thing I'd like to say, I guess, is that it was a little too late, but what we established at Milton Keynes was nothing short of remarkable, I think. We would essentially, within a month, were in a position where we could offer a PCR diagnostic test for a notifiable infectious disease to anyone in the country that wanted it. And bear in mind, as I said, that was all staffed by volunteer staff primarily. I think it's one of the proudest achievements of my career. Just like I say, a little too late, I felt, to impact Wave 1.
Thank you. The image can be taken from the screen. But can I ask you, because plainly there's been a lot of commentary around the involvement of the private sector that was used to set up the logistics and procure matters.
Yes.
Obviously, you no doubt would have worked hand in hand with consultants from Deloitte and probably other procured companies. Is there any observations or insight you can provide about the role and experience, and good or bad, about the private contractors, please?
I think some of the companies like Thermo Fisher, Tecan, who provided a lot of the automated liquid handling devices, they worked very hard. They were with us overnight. I think I had a lot of frustration with the involvement of Deloitte. They had an enormous team in situ in Milton Keynes providing project management. I felt at times the project management got in the way of what we were trying to achieve in the laboratory. There would be questions about, can we tweak amounts of reagents, can we speed up things, and there was a lack of realisation that if you do that, you're no longer doing an accredited test, you have to revalidate it. So at times it was very frustrating dealing with colleagues in Deloitte. Like I say, this project absolutely required the very highest level of project management. I was unconvinced that we needed quite as many of them as we had on the facility. And very often they would be doing, multiple people would be doing the same thing.
Thank you. Can I then, as a separate point, within your statement, there's a number of times where the word frustration appears, but can I take you to paragraph 38, please?
Yes.
INQ 587245. Now, you detail at paragraph 36, the narrative that was created around the Lighthouse Lab Network was that it was a triumph of the private sector working in cooperation with government. This provoked frustration in me, as the enormous role played by higher education was often overlooked. Of course, the private sector was pivotal, with companies such as Tecan and Thermo Fisher putting huge resource and focus into the testing infrastructure and capacity, but also to their financial benefit. What is overlooked is that Milton Keynes Lighthouse Lab and the labs in Cheshire, Glasgow and Belfast were all established with equipment belonging to universities, and were all staffed by university researchers or seconded civil service laboratory staff, with many such as myself taking leading roles in the process. In my opinion, the most confusing and frustrating involvement was the reliance on a large number of Deloitte consultants to project manage the Lighthouse Labs, as they had no expertise in laboratory work, infectious disease or diagnostics. I often find myself having to spend lots of time explaining concepts and facts to the consultants and having to set realistic expectation of what was feasible again and again. I do see the importance of having exceptional and experienced project managers for such a complex and important project as the Lighthouse Lab Network, but did not see the need for the number of consultants I encountered in my time in the network. As an example of how I was often not impressed by their project management, on April the 2nd, there was a sudden realisation at Milton Keynes Laboratory Lab that we did not have the logistics expertise to supply the lab with the consumables and reagents needed to conduct tens of thousands of PCR tests every day, despite the number of consultants on site and their responsibility for planning. one of the consultants had joined Deloitte from the military and reached out to contacts, and on April the 3rd, troops from the Royal Army Logistics Corps arrived on site, setting up an industrial warehouse of consumables and reagents, making inventories and taking complete control of stock. Their involvement was transformational to Milton Keynes Lighthouse Lab, and testing would have quickly ground to a halt without their logistics expertise.
Yes.
Is there anything you want to add to that, or does that essentially speak to?
I hope it speaks for itself. And I guess just to explain why I didn't spot that, in a university lab, you may be lucky if you do a couple of hundred PCRs a week. I had no idea of the scale of exercise and running 30,000 tests a day. And we just things like waste disposal, we had no idea how complex the logistics around that were going to be.
Thank you. Now, we know that you set it up with your knowledge and experience, and I, this morning with Sir Paul, was able to capture in a very quick way the names, hundreds of names of individuals in the CRIC consortium. I think you yourself would actually, without naming them but by number, identify that army of volunteers that assisted you in setting up the Lighthouse Lab.
Yes, absolutely. I mean, I'm sitting here today because I had a leadership role in that lab, but there are over 200, in my opinion, real COVID heroes who gave up their lives for 3, 4, 5 months to basically provide testing for the UK. And I don't feel that's ever been formally recognised. I think we took for granted the fact that anyone could go to a walk-in test site and get a PCR test for COVID. What they didn't realise is that under the bonnet of that were hard-working volunteers making that happen.
Now, I'm going to briefly ask you just to summarise to Her Ladyship, because when you left Deloitte, you did then, were part of the Lighthouse network where the University of Birmingham did do some testing for Pillar 2. But can you just deal with that to Her Ladyship, but also contextualise it as to whether any other laboratory other than the University of Birmingham was doing it, please?
Yeah, so the reason I left on 1st of June, because I felt that Milton Keynes was running seamlessly, it was running perfectly. Lots of staff had been trained to a level where they really didn't need me there. And the university was reopening, and I felt in my leadership role in the university it was important I returned back to campus. I'd been back on campus a month when I received calls from employees at Deloitte asking if I would engage with them in the process of setting up a Pillar 2 laboratory at University of Birmingham, essentially what I'd been arguing we should do in February. And then between July and September of 2020, we worked to establish a mini Milton Keynes on the University of Birmingham. A couple of other universities were brought into the process. To my knowledge, to my understanding, University of Birmingham was the only university lab that actually ran accredited Pillar 2 tests for the network.
And are you able to offer any insight or observations as to why the University of Birmingham, outside the main Lighthouse labs we could see, was stood up for a period to do testing? Possibly my role in Milton Keynes, and there was maybe a trust that we could set that up. If I could offer a slightly cynical approach, is that very often it's easy to keep your enemies closer. I could have been seen as a bit of a fly in the ointment, but I have no evidence of that, just a hunch. And you detail in the statement that essentially that testing was also used for surge capacity to test University of Birmingham students in, I think, the winter, November time,
yes.
2020.
So essentially what we created in Birmingham was exactly what Sir Paul was suggesting. We had, on one of our university car parks, there was a walk-in or drive-through test site. So you could register for a test, walk into that car park, be tested. That test would then be transported to our laboratory in the university where we would test it. And we were delivering results within 24 hours back to people who'd been tested. I was also the benefit of being a member of the COVID Genomics UK consortium, and we were able to hand positive samples directly to my colleague, Professor Nick Lohman, who could then do the genome sequencing within another 24 hours, which meant we were going from test to epidemiologically informative result within 48 to 72 hours.
Thank you. Now, I think you provided, attached to your witness statement, essentially the letter thanking you and the University of Birmingham for your efforts, but essentially you were stood down from the 26th of February 2021 from that effort.
Yes.
And did you do any contribution of testing after the 26th of February?
We then began a ramping down process, and we ended it on the 31st of March completely.
Thank you. Now, final topic before I deal with recommendations. You, I think, have been quoted within a number of articles about the sensitivity or the accuracy around the Amenza
Yes.
scandal. Can I just ask you to give a summary to her ladyship of what the concern was or what the issue is from your perspective, please?
Yes, I think when I was involved in Milton Keynes, we were really under the microscope, and UKHSA and NHS England really scrutinised the quality of the provision that we were providing, the quality of the test data, and whether or not what we were doing could be trusted. And that was also the case when I set up the lab in Birmingham. We were under the gaze of UKHSA and NHS England to make sure that our testing was as good as it needed to be to contribute to the network. Clearly what happened with the Amenza laboratory in Wolverhampton then in 2021, where up to 500,000 test results were incorrectly reported to members of the public, suggests that strict level of oversight, something happened there. Because if that had happened in Milton Keynes, that would have been picked up on within a couple of days. And if it had happened in a lab in Birmingham, it would have been picked up in a couple of days. So I don't have any evidence, my lady, but it does suggest that really rigorous oversight, something happened to that in that time frame.
And I think I'm going to quote from the article that you contributed to. I think you're recorded as saying, in the long list of COVID disasters and scandals, this is pretty near the top. You shouldn't be relying on anecdotal reports to spot a problem of this size. That's the unforgivable thing about this. I don't think it's going too far to say that an absolute failure of quality in that lab is going to lead to very serious illnesses, maybe hospitalisations, and maybe worse.
And I believe there is now proper data to confirm that there were avoidable deaths as a result of the Amenza mistakes. Particularly in the southwest of England.
Thank you. And I think the anecdotal evidence that picked it up, I think it was actually just a member of the public that was it that accessed data?
It was members of the public in the southwest of England who were saying that lots of test results were coming back as negative, but people were falling very ill. And it was strange that it seemed to be co-located in a particular part of the country. And then some very astute scientists started to pick up on the fact that a lot of this data is in the public domain, started to look at it and started to see quite an alarming level of negatives, way below what would be expected in any of the testing labs, given the incidence at the time.
Thank you. You have given a large portion of your statement over to recommendations, which will all be carefully considered. Can we go to your statement, please? INQ 58724. Those lessons learning and recommendations start at paragraph 40. Let's move along the pages, please, so they can be captured. I'm displaying them on the screen, but then having done it in a very high-level way, and with the time we've got, can I ask you to, because the others have questions, is there any driving recommendation that you would wish to commend, or a number of them, because plainly there's a great many you've given thought to and reflection, that you would indicate from your perspective, with your knowledge and experience, you think are lacking still now, and it's essential that is implemented?
If I may, I think the one pressing thing is that all of that testing infrastructure we created no longer exists, no part of it at all. It was all wound down, equipment was sold off, labs were closed. And if, heaven forbid, SARS-CoV-3 happens in December, we will be exactly where we were in January, February of 2020. There is no way to scale up testing quickly. I would urge that we look at the model that's employed in Germany and South Korea, the federated lab model, look at how much that would cost to implement and maintain, such that we have the capacity to stand something up quickly, like Sir Paul did in the Crick and like we did at Birmingham. I think it's essential, because we will be, in terms of delivering tests, we'll be exactly where we were at the start of 2020.
Professor McNally, those are my questions. A number of core participants have questions for you.
Ms Mara.
Professor McNally, I'm Thalia Mirage, and I have some questions for you in relation to your experience at the Lighthouse Lab, and I ask questions on behalf of the COVID-bereaved families. You were taken just now by Ms. Cartwright to your experience in setting up the Lighthouse Lab back between March and June of 2020. And you've spoken of some of the challenges you faced in the early stages and some of the positives. And I want to ask you just a few questions about some of the negative reporting of the experiences at the Lighthouse Lab. And I want to make reference to a report that was covered in the BBC back in October of 2020. And I'm not going to bring it up on the screen, but for the records, it's INQ 000228145. And this report documented some of the experiences of a virologist, Dr. Julian Harris, who described the article is entitled, actually, Coronavirus Lab Testing, Chaotic and Dangerous. And that is a caption of his description. And it reported health and safety executive breaches at the lab back when he was there in July of 2020, which included inadequate health and safety training for staff, employees working too closely together, and other workers there reported poor safety protocols, lack of suitable PPE, including a report by a PhD student, presumably a volunteer as well, of being asked to wear cheap disposable lab coats and plastic gloves attached with a parcel tape. So this is the experience reported back in July. Now, my question to you is, were you aware of these sorts of experiences and complaints back in your time there?
The first thing I'd like to point out is that report occurred after my time had ended at Milton Keynes. I can say that it bears no reflection to my experience while I was at Milton Keynes. There were proper Howie lab coats, as is a legal requirement in the containment level 2 laboratory. There was sufficient gloves, etc. So not really indicative of my experience. With regards to the comment, well, there's two things. The Health and Safety Executive Report is in the public domain. There were no major concerns, actually, in that report. There were a number of recommendations, which is fairly normal for an HSE visit to any laboratory. But there were no major concerns, which is where the HSE would say, OK, we're really worried about this, you're not doing this properly. I think the other thing, and I feel I need to address this, because in that report, the gentleman talks about 2 people working at a cabinet and how that makes it unsafe. I was actually part of the team that made the decision to have 2 people working at a cabinet, but there's only 1 person working in the cabinet. You need 2 people to process the test. Essentially what happens is you have a 96 well plate with a barcode that's scanned into the lab tracking system. That's then placed into the cabinet. And then a sample with a barcode from the testing system is scanned by an operator, and he passes that into the cabinet. And what happens then is that sample is allocated a specific well in the 96 well plate so that it can be tracked all the way through the lab until the result is given. Now, you cannot have 1 person in a cabinet doing that, because they'd have to be bringing their hands out, and that's not safe. So we had 1 person in the cabinet and 1 person standing next to them to do the scanning and witnessing that the sample had been placed into the appropriate well, which is very important. And it was myself, Mike Hill and Stuart Moffat made the call that we absolutely would have that as a minimum requirement, because we would absolutely not tolerate an incident where someone was given a result, but actually it wasn't their sample, it was someone else's. So that's why, but 2 people never worked in the cabinet. It was only ever 1 person.
Okay, thank you. Just to pick up on your observation in relation to the Health and Safety Executive Report, because actually the BBC investigation reported that the findings, so whilst there wasn't a reporting or sanction, the findings of the Health and Safety Executive was that there was inadequate health and safety training for staff and employees, right? So that was one of the findings.
Yes.
And my final point, just picking up on something, your observation in terms of your timeline, the virologist who makes the report to the BBC speaks of his experience in July, and we appreciate that your timeline was up to June.
Yes.
Thank you.
Thank you, Ms. Barrage. Mr. Thomas. Mr. Thomas is over there.
Good afternoon, Professor McNally. Let me introduce myself. I'm Leslie Thomas, and I'm representing the Federation of Ethnic Minority Healthcare Organisations. Just a little bit of context. The questions that we seek to ask are in relation to the pandemic preparedness, specifically regarding the testing infrastructure and the potential for university labs to support early community testing efforts. So with that in mind, let me come to my questions. Professor, in paragraph 18 of your witness statement, you advocate for scaling up testing through smaller lab consortiums in February 2020, which you believe would have given us a head start in tracking the virus. Could you explain how this early initiative, particularly if it had been implemented at a larger scale, might have benefited minority ethnic and other minoritized communities in terms of both access and protection?
I'm not an expert in this area, and I think Professor Fraser and Professor McKee on Tuesday spoke to it much more eloquently and more informed than I can. But as an example, we had excellent local directors of public health in the West Midlands at that time, specifically thinking of Lisa McNally, who's not a relative of mine, I should add. And Lisa did a fantastic job of going out to marginalised communities across the West Midlands and communicating the need to test, the need to get a test result, support with isolation. That was transformative in the West Midlands because I think that centralised message of get a test, that doesn't pervade all the way through society. And the work of people like Lisa and also Justin Varney, who was the Birmingham Director of Public Health, they spent an inordinate amount of time and resource on trying to get the message to marginalised communities. And we have quite large Eastern European migrant workforce communities as well. There was a huge amount of work done in trying to engage those communities with testing, and the university actually even helped with a lot of translation materials, such that the message about get a test was got across. So I don't know if I'm answering your question, but I think that's how the localised setup can help, because I think Sir Paul said it. Local public health, working with local universities, working with local NHS trusts, has a far more powerful and compelling case than everything being centralised.
You've highlighted the untapped potential of university labs in testing early in the pandemic. In hindsight, how could universities have been better mobilised to improve testing access for minority ethnic communities and other marginalised communities? And in particular, were there any specific measures that could have been taken to ensure that these institutions played a greater role in community testing, particularly in underserved areas?
Again, I'm going to give a relatively uninformed response to that, but again, around my own experiences in Birmingham, which would be where, as I said, we worked with local public health. So even though we had a Pillar 2 laboratory, there were occasions where the Director of Public Health would come to us and say, we think we may have an outbreak in a given community, and can we give you some swabs and can you run them for us? And we could do that very, very quickly. Whereas if it'd been a case of them having to go to a walk-in test site and those tests go through the national system, then that you can imagine that wouldn't have worked so well. So I think, again, it comes back down to the partnership between local public health, smaller university labs, local trusts working together to provide targeted testing where it's required.
So this is my final point. So trying to be forward-looking.
Yes.
God forbid the next pandemic. What would be your advice in terms of just looking forward and being prepared?
I think, as I've said, I think we should really examine implementing the kind of federated lab system that they have in Germany and South Korea. It can be stood up incredibly quickly, and then it can work at a federated local level with oversight from UKHSA, the DHSC, providing that project oversight and making sure everything's joined up. But I really would strongly advocate that we need to, you said, heaven forbid, there will be another pandemic in the near future. And we need to make sure we're ready for it, better prepared for it than we were for COVID. We got lucky with COVID.
Milady, thank you.
Thank you, Mr. Thomas. Those are all the questions we have for you, Professor McNally. You rightly praised your colleagues. As the more I hear of this inquiry, the more I realise how many thousands of unsung heroes there were. So thank you for that, and I endorse your comments. But also thank you for the way you stepped up to help the public of the United Kingdom. You could have sat in your tent and sulked when your advice wasn't accepted, but you didn't. You bit the bullet and you got stuck in. So thank you for all that you tried to do.
Thank you, Mike.
And all that you did do, not just tried to do. Thank you very much. I shall return at 1:45.
All right.